Thank you. I've been in practice for 35 years now, and we now treat a large number of MS patients at my clinic in Fullerton. I have a physician assistant, a nurse practitioner, an MS certified nurse, and we have an infusion suite. And I want to talk to you about these very new and exciting drugs coming out. And some people have viewed this as a tsunami of MS drugs. And there's going to be wave after wave of these drugs. And I think it's a very exciting time. And what's going to happen, we're going to go over these drugs several times in the course of this. First drug to come out is not a new drug. It's called Extavia. And that is the beta-seron brand that Novartis is going to market. The next drug, that should be out in 2009. The next drug, hopefully, will be cladribine in 2010. FTY 720 may come out in 2010. The following year, probably, we won't have any drugs, but in 2012, we hope to have Campath, laquinimod, possibly a myelin basic protein, probably fumarate. So over the next two years, possibly 3. Now, this, I don't have a slide for this, but there was a new study just finished this past year that says neurologists who treat MS patients, when they're surveyed as to what they want out of MS drugs, they want better efficacy. MS patients want oral drugs. So what's going to happen to those of us treating MS patients is when oral drugs come on the market, I think our dialogue with MS patients is going to really change, and it's going to be more of a partnership with the patient. And oral drugs, I think, are going to change compliance greatly. A study done at about the same time shows that 20% of patients who have relapsing and remitting MS put off starting medications. Of those 20%, half of them don't start for six months, and then of that 20%, a third don't start for a year. And the basic reason is the fear of injections. Objectives were there before, and we're going to talk about the oral drugs mainly. I will talk about some of the monoclonal antibodies, and I'm starting to think about choosing patients now. So as you go through this, I think it'd be very helpful. Try to think of what patients fit. Laquinimod is a Teva product. This is an oral drug. It has once-a-day dosing. Now, it is similar to a drug called linamide. And linamide was an effective drug, but it had toxicity of serositis, which could include pericarditis, pleuritis, iritis. And laquinimide was developed with the hope that it was safer. And when you hear about these drugs, I think it's important to try to understand, is it an immunomodulator or suppressive or both? Now, the definition of an immunosuppressive is not really clear. Consensus probably is if a drug can cause opportunistic infections, then it's an immunosuppressive drug. Laquinimide is an immunomodulator, and as you can see, it shifts from Th1 to Th2. Th2 is better than Th1, and it increases anti-inflammatory cytokines. It does not affect the immune response.